ask questions. Okay, so let's see here. I'm gonna make this so that I don't have to see myself. Right. There we go. Okay. And let me put it in slideshow view. Okay. All right. So we are here, like I said, to talk about newborn screening for SCID. And let's see. All right, so I'm going to start with a little bit of a case. Just this is a real patient that I saw here. It's been a few years now, but I just thought it makes it easier to understand when it's an actual patient we're walking through. So this was a little girl born at 38 weeks, full term via C-section, normal birth weight. She passed her hearing test. Her first couple of days of life were uncomplicated. She was sent home with mom and dad and was doing absolutely great at home. So truly no sign that anything at all was wrong. She did have a newborn screen sent between day of life 1 or 2. And then, oh, sorry about this formatting. And then it resulted on day of life 5. So here is an example. This report format has slightly changed since then, but I get a call from the Virginia Department of Health about a critical result for severe combined immunodeficiency, or SCID, as we like to call it, because it's a mouthful otherwise. I'm going to walk you through kind of what does that mean? What does that indicate? What should you do if you are the pediatrician who is simultaneously notified by the Virginia Department of Health? You get the call just a few minutes before I do, typically. So what are you supposed to be thinking about? What are you going to do? Okay. What is SCID? So SCID is kind of colloquially, you might have heard of it as the bubble boy disease. So for those of you who don't know this story, this is actually fairly recent history. And it sounds like something out of a TV show or movie, but it was real life. This is a little boy, David Vetter, who was born with SCID and who they knew he had SCID because he had a sibling who had passed away from it. And in the case of SCID, it's a condition in which you're born without any functional T cells, rendering you incredibly susceptible to infections. And so the solution, and all they could do for David at the time, was to keep him in a bubble, literally. So he, with the help of NASA scientists, they created this bubble and he grew up there. So you can see he celebrated his birthday eating a canned birthday cake that was sterilized. He read books and had stuffed animals that were passed to him through these sterile portals. He played in here, and it wasn't until he was many years older that he was able to even leave the bubble in a spacesuit and actually walk around. So, it's actually this link here. I don't have time to show you the clip. It's incredibly heartbreaking to hear about this child's story, and that this is how he had to live the years of his life until he was around 14 when he ultimately passed away. So the bubble boy disease is what it's known as in layman's term, but we call it SCID. And what SCID is, as I mentioned, all forms of SCID are defined by the absence of T cells. And what are T cells? So T cells are part of your white blood cells, your lymphocytes, that really help coordinate the immune response to infection. And so there are all sorts of flavors of SCID. There won't be a quiz on this later, but various forms of SCID have different effects on the other lymphocytes, the B cells or the natural killer cells or the NK cells here. But the unifying thing that defines SCID is the absence of T cells. So, screening for SCID, and I'll talk a little bit more about how this is done in the next few slides. So screening for SCID began in the United States, so in 2008, with our very first state, Wisconsin. Virginia began screening for SCID in 2015, West Virginia in 2014. So we weren't early adopters, but certainly we're right there with many other states in adopting this for our newborn screening panel. And by 2018, every state in the United States is screening for SCID. So we've been doing this now for 5 or 6 years in Virginia, in the United States, and for almost a decade here in Virginia. So we have a lot of experience with this. And I want to kind of walk you through what you need to know about it, because it may have been that since you left training or since or wherever you trained, that you were in a state that didn't screen, or we weren't screening at the time. So this may be new information to some of you. So why do we screen for SCID? Well, we screen for SCID because it used to be the way you figured out that a totally healthy baby, like the girl that I mentioned to you at the beginning, had SCID was because they developed an infection, right? And so if you look back before we started to screen in red, most of the diagnoses were made that way, is because someone had an infection. And the problem with that plan is that those infections were often fatal or left people with lifelong consequences. And so that's not how we want to find out that a baby who otherwise physically will look completely normal has a life-threatening immune deficiency. We want to find out, and we also don't want to have to find out because they have a family history like David did of a sibling who died from SCID. We'd like to find out proactively. And so now, with the advent of newborn screening, almost all of our diagnoses of SCID are being made by Newborn Screen, which is a real success of the screening programs. So what does screening look like in Virginia? So as you all probably know, we screen every newborn in the state at days 24 to 48 hours of life, unless the parent specifically opts out for religious reasons. It's done by heel stick and a dried blood spot that goes on these Guthrie cards that are then sent to the Department of Health in Richmond. And then the Department of Health is responsible for following up all abnormal and critical results. And they continue to follow up on them until they either get a diagnosis or they're notified it's normal, or the infant ages up out of their screening program at 6 months. One of the big challenges for this is that the newborn screen is a dry blood spot. And so when we were thinking about how to screen for SCID, we can't use what we normally do to look at white blood cells, which is a CBC, or a test I'll talk about in a minute, flow cytometry. We had to figure out how to use something that could be stuck on a card and would be able to be mailed and be stable for several days, right? And it has to be something that's relatively fast and low cost. And so those types of testing, it can't be something that is our traditional methods of diagnosing low T cells. So some amazing immunologists thought about it and realized that when T cells are made in the thymus, which is the gland that sits in front of your heart, during development, they undergo a process called VDJ recombination. Don't have a seizure for med school. I'm trying not to give you any trauma, but during VDJ recombination, essentially, some junk DNA gets cut out that's not used. And that junk DNA is called a TREC, or T cell receptor excision circle. And so if you look for that junk DNA by PCR, you know that if this was cut out, it was cut out in the process of a T cell being made. So it's indirect evidence that we have T cells being made, which is really what we want, because as I told you, all forms of SCID are characterized and defined by the lack of T cells. So this is what it looks like. So they take some DNA and they amplify the TRECs using probes, and it's a log scale. And with every cycle of amplification, you double the amount of DNA that is present. And eventually, with enough cycles, you reach, so these are the number of cycles on the x-axis, you reach a threshold of amount of DNA. And once you reach that threshold, they look at how many cycles it took to cross that. And so in a normal child, by the Virginia Department of Health, normal cutoff is somewhere around 34 to 38. Don't quote me on those exact things, but ballpark around there, 34 to 38 cycles. And so what happens in SCID, though, is because you don't have any T cell receptor excision circles to start with, no matter how many cycles of amplification since you started to zero, doubling of zero over and over and over again still results in zero. And so what happens in normal infants is you reach the cycle here, but in babies with SCID is that you never reach that, right? And so in a case of an infant with SCID, we would have a very high number of cycles needed to reach the threshold, or in many cases, we never reach it. And this is just to show you just an inverse relationship. The more cycles is the less starting DNA you have. Okay, and this is just showing you what it looks like in 8 cases of SCID, right? So we're continuing to try to amplify. And in this case, only 1 of the 8 samples ever made it to the threshold, and that was very, very, very late. The other thing I want to draw your attention to is this internal control called RNase-P. This is to make sure that the test didn't fail, right? So if we didn't amplify, is it because we just didn't put enough DNA, we didn't put all the reagents in, the machine broke, whatever. We want to make sure that this is a valid test. This is an internal control. All right. So what might you see as a pediatrician or an internist or family practitioner on your results? So the result that you will see by and large is normal, right? And so when you get a normal result on a TREC assay, that means they detected TRECs, and the TRECs mean that there were normal numbers of T cells being made. And so that rules out SCID, because SCID, by definition, you wouldn't have T cells being made. And it also rules out the very severe T cell lymphopenic states, right? And of course, in order for the Virginia Department of Health to report that it's normal, they are telling you that the assay control, the RNase-P, worked. So they will not report a normal unless the assay is confirmed to be valid. The next possibility is they're going to tell you it's abnormal. Abnormal means that they found some T cells, but they weren't there, potentially in normal numbers. And it could be anything from a false positive screen, and I'll show you that, to no T cell lymphopenia to very significant T cell lymphopenia. And again, assay control has to have worked. And then there's the one that makes immunologists' heart stop, which are these criticals. They also sometimes use language of undetermined or indeterminate, which means that it took either above the threshold number of cycles to reach the threshold, or they never managed to reach the threshold, no matter how many cycles of amplification. And so that is the most likely scenario of result that you're going to get in a patient with true SCID. And once again, those patients have to have had a positive or a valid internal control. I say all those valid controls, and I'm harping on that because the scenarios that you're also most likely to hear is this report term called unsat or unsatisfactory, and that means the assay just didn't work. And that is different than abnormal, right? So the assay not working doesn't mean the baby has a normal, abnormal, or a critical number of T cells. It means they just can't tell you because the assay didn't work. So you should not be either alarmed or reassured by the absence, by an unsat result, because it doesn't take anything about their TRECs. That being said, the Virginia Department of Health has a protocol to recommend repeating the screen when it's unsat, but eventually, as you'll see, we're in a race against time and infections with SCID. Eventually, they will report out with 3 unsats in a row a test as abnormal, so that you can just avoid any potential delays. They're just kind of saying, listen, for some reason it's not working. Let's try something else. A couple of comments, sidebars. These are my editorial things. I see that Mary's on the call. Mary, don't kill me. These are my personal pearls. So in Virginia, we frequently repeat, or our protocol is to repeat the newborn screen to follow up an abnormal in many disorders. And that's particularly true in preterm infants, right? But it's the entire panel that gets repeated. And so sometimes you get in this scenario where a baby had a newborn screen that was normal for SCID, and then maybe when they're 3 months or 4 months or 6 months of life, they get another newborn screen done to follow up a completely non-SCID diagnosis, and it becomes abnormal or critical. And the question is now what? Now do I have to chase that one? And that comes up all the time. I get those calls a lot. So I always say once normal, always normal. So if the baby was making T cells at some point, That's evidence they have a thymus that's working and they have T cells. Now, there are case reports in the literature of that not being true, but I still stand by my once normal, always normal. So you don't have to lose sleep over those. And then the other one that I know that comes up a lot lately is if a baby tests positive for multiple disorders. So the one that's been happening a lot lately has been SMA, one of our new disorders, and SCID. In theory, an infant can have more than one genetic disorder. So in theory, you have to treat as if that was a valid positive screen for SCID and chase it with confirmatory testing. But I think with time, we'll probably sort this out. And I suspect this has something to do with some sort of assay problem. But for now, I'm telling everyone to treat them as if they're true. Okay, so what does the scope of newborn screening for SCID look like? Well, this is some data from California for 7 years of screening. They screened over 3.5 million infants with abnormal TREC. Okay, so they screened 3.2 million infants and only 562. So 0.017% of them ended up abnormal. And then required confirmatory testing, which is called flow cytometry. So that's here, a very, very small portion of the children. Of those infants then who screened positive, which are the ones that you will be getting called about and that I'll be getting called out, only 1 in 3 actually had low T cells, right? So it is not highly specific. The test is designed to be sensitive, not specific, which is what you want for a screening test. So only 1 in 3 kids with an abnormal newborn screen are going for SCID are going to actually have low lymphocytes. And of those ones that have low lymphocytes, only 1 in 4 are going to have SCID. I say this so that when you're talking to parents who have abnormal newborn screens for SCID, you're very clear that this is a screening test, right? So statistically, your child does not have SCID because statistically, most of these babies with abnormal newborn screens don't have SCID. That doesn't mean you should ignore it. And that doesn't mean you shouldn't do the confirmatory testing. And that doesn't mean it's absolutely critical to follow up on it. But I think we have to walk a line between and how we counsel our families about it. All right. What else can cause abnormal newborn screens? Almost everything, mostly syndromic conditions like trisomy 21 or 22q11 deletion. The one I want to raise your attention to, though, is these preterm infants. And so almost all preterm infants will end up with an abnormal newborn screen, depending on how preterm or how low birth weight they are. I won't go through all this data, but this is a really nice study that looked at T cells here based on gestational age. And as you can see, sorry, I'm looking over here. As you can see, they kind of increase with time. And so it's not surprising that the more preterm you are, the lower your cells. So for me at UVA, and I hear a NICU baby has an abnormal newborn screen, I just tell them to repeat it until they get to be closer to full term, unless that result is critical, in which case I act on it now. All right, back to our baby, and then I'm going to wrap up in just a couple more slides. So what happened with our baby? Our baby had a critical, as I told you, and so now you understand what a TREC value of no cycle threshold means. That means they never amplified the DNA to a satisfactory level, and the RNase p-value was acceptable. So they repeated that 3 times, and then they said, okay, we think this is real. And they called it to me. What do we do when we think this is a real SCID? We do the confirmatory testing I've alluded to, which is called flow cytometry. I won't bore you with all of these nitty-gritty details, but the bottom line is what we're looking for is very, very low T cells. Now, not by the screening test, but by the confirmatory test, which is to actually look for the direct presence of those cells, not the indirect evidence that the screening assay is looking for. All right. So what should you do if you get an abnormal or critical? If it's a low birth weight infant, I recommend you repeat it unless there's a clinical concern or a family history, like the baby has unexplained severe infections, or they say the baby's sibling died of SCID, or I have a family history of unexplained infant death, then you may want to act sooner. That's if just abnormal and preterm, because we know prematurity is the most likely explanation. If the value is critical in any infant, preterm or term, or if it's a term infant that's still abnormal, I then do the confirmatory testing, which is flow cytometry. If you order the flow cytometry, which is available through, Quest, LabCorp, Mayo, many local hospitals, and you get an abnormal on the T cells, or you can't get the flow, that's when it's time to bring in an immunologist. While you're waiting for all of this to happen, obviously don't give live vaccines. Remember, rotavirus is given at 2 months. So you want to avoid giving that until because they can get actually disseminated infection from the live virus. If they do need blood, this is pretty standard NICU protocol, but CMV negative irradiated leukoreduced. And then this one is controversial, but many immunologists will say if you're concerned for SCID to not breastfeed and to either pump and freeze the milk to feed later until the testing is back, or to just and to use formula in the meanwhile. The reason for that is because of the potential for maternal CMV transmission to the baby, which could be fatal. All right, so this little baby, what happened? She came in, we did the flow cytometry testing at day of life 6. So remember, it resulted on day of life 5. We saw her the very next day. It confirmed she had essentially absent T cells of her own. She had some of mom's T cells. She had very low B cells, and she had normal natural killer cells. Consulting her handy dandy diagram, we made a diagnosis of SCID in one of these likely genetic defects as the cause, and we confirmed, in fact, that was the cause using genetic testing. So what should you do if you happen to be at the pediatrician caring for a baby who has SCID now? Now, this is not the screening state. This is actually they have SCID. Well, it's all of these things, right? So isolate the baby, protect them from infection, either at home or in the hospital. Prophylaxis with antibacterial, antiviral, and antifungal. Stopping the breastfeeding, as we talked about, due to the risk of CMV. And then you've got to get them to a transplant center, and I'm going to show you why. So SCID is very treatable. So if we can transplant these babies with bone marrow transplant before they get an infection and before they're about 3.5 months of age, we have a 94% survival rate. On the other hand, if we wait and we diagnose them because they come to our attention because we didn't screen and they have an infection, or they get an infection even despite our best efforts, it can be as low as a 50% survival rate. If they're never diagnosed, then it's uniformly fatal by the age of 2. So clearly, we have a huge opportunity to take a disease that's uniformly fatal to a 94% survival rate, but we have to act fast, and we have to do quite a lot of coordinated care, which is where we as immunologists would love to partner with you all. All right, so just a little follow-up about my baby before I open for questions. So this little baby got immediately started on all the right things, referred for transplant up at Children's in Washington, D.C. She made it with a fully matched unrelated donor transplant at age 3 months and 3 days and went home with mom and dad at age 4.5 months. This was her. This is all with her family's permission. This was baby Evelyn when she was first diagnosed, healthy little girl who no one would ever know had this. This is her when she was a couple of months old with her parents finally hearing the words, "She's cured." And then this is her at Disney World meeting her donor when she was a few years later. So truly saving lives. And so this is really an important topic, and we really can save children's lives. I'm grateful to all of you for listening, and I will stop and see if anybody has questions.
All right, does anyone have any questions? All right.
Monica,
Okay.
Monica,
Yeah.
I just have a quick question. This is a
Yes.
great talk. Thank you so much. I wondered, and forgive me if I missed it, if you might comment on infants born to diabetic mothers and how
Oh.
that plays into some of the false positives.
Yeah, that's a great point. So Dr. Ryder is feeding me questions because he's our other expert immunologist working with me on PEPI, for those of you who don't know him. So yeah, absolutely. So infants of diabetic moms can absolutely have very, very low T cells, and that can be a slightly different pathway of treatment, right? So those babies, along with 22q11 deletion syndrome babies, the problem is not in their bone marrow. The problem is typically in their thymus and so itself. And so we need to approach them slightly differently. That being said, that's for the immunologist to sort out whether they need a bone marrow or a thymic transplant. For you as the physician getting the call or taking care of the baby, I think I would say all the same things. But Dr. Ryder, if you disagree, feel free to say how you view it. I'd love to hear.
No, I agree wholeheartedly. I think that, what you shared about the preterm infants, and then I think also the infants of diabetic mothers are kind of two big categories of individuals who have false positively low TREX. False positive meaning they don't have an underlying T cell defect, but I think you covered it beautifully. Just wanted to touch on that just so that our colleagues understand that that's also an issue. But agree wholeheartedly with you in the management as expected.
Thanks for the confidence. I'm curious. Well, let me see if anybody else has questions that they've mulled while we were
Dr.
chatting.
Lawrence, I have
Yes,
a
ma'am.
quick question. So I am practicing in Maryland, and we have to do like a repeat of the newborn screen at usually we do the 2-week visit, but can do it up to the 1-month visit for wellness. And so I was just curious, you might not know this because you're in Virginia, but is that common in other states? And is the rationale because of like the preemies and the diabetic moms, or is it just there's just a lot of confounding factors and this is routinely done in a ton of different states?
Karina, that is just perfect timing. So I actually am participating in this effort to understand how every state that's currently screening and how every country in the world, which is around 80 at this point, that is screening is approaching this. And so not most, but some. You're not the only state that does a 2-step newborn screen. And it creates some confusion because frequently what you see is a normal on that first screen and then an abnormal on the second screen. The way I like to think about it is that the thymus is sitting here full of T cells that are just waiting to be released into the bloodstream. And so it just kind of dumps them all out at once. And so you expect that thymic output to be high and then to drop with time. And so if I were you, Karina, and I got in that situation of a normal first screen and an abnormal second screen, I would be reassured by that. The converse of 2 abnormals or criticals would be much more concerning.
Sounds good. Thank you.
I just had a quick clarification question. Thank you so much for your lecture.
Sure.
When you were talking about prophylaxis, you mentioned the palivizumab, and now we have this new antibody.
Yes.
I didn't know if that had been studied yet in this population or not, and if you prefer, or if that is preferred over the palivizumab.
Yeah, great question. So it's not been studied to my knowledge, although I welcome Dr. Ryder, Dr. Borish, anyone else's input on this. I don't think it's been studied in a formal way. But we do like to rely on passive immunity with the monoclonal antibodies as a way of prophylaxis, because these infants can't generate their own antibodies. So anything that is a passive immunity would be reasonable.
Great, thank you.
All right.
Is anyone else? Oh,
go ahead.
Sorry.
No,
Go ahead.
No, you go ahead.
I just wondered if anyone else has any more questions.
Oh, I'm sorry. I just thought of another question because I am breastfeeding my child, and I would not have thought about, the risk of CMV. I would have been like, here's some passive antibodies. Yes, let me keep breastfeeding you. So Is there a way of testing the mom, having the mom be, I'm family practice, so, you know, theoretically, the mom could also be my patient. Would it be any beneficial to test her for CMV? And if that's negative, then say, okay, you're good to breastfeed while we're waiting, or what would you prefer?
So I wrote in there controversial because I think one of the most devastating things to tell a mom who's committed to breastfeeding is that you have to interrupt that breastfeeding relationship for what could very well be a false positive screen, right? And so at the same token, we do know that CMV can be fatal and predicts much worse outcomes if you don't die from it. And so you're kind of weighing a small but very terrible risk. So most hardcore immunologists, I'm interested in Dr. Ryder and others' thoughts too, will say don't allow the mom to breastfeed at all. I have been known, especially for the abnormals, to do exactly what you said, which is to test the mom for presence of CMV antibody and test the baby's urine for CMV. And if both are negative, with strict isolation precautions in place, allowing them to continue to breastfeed. The issue is that they're negative for CMV on Monday, they could get exposed on Wednesday, right? So you're capturing a snapshot in time. So it's tricky. And it's certainly a risk. But I feel you, because it breaks my heart every time I tell a mom not to breastfeed. Dr. Ryder, do you have other thoughts?
No, I mean, I agree. And I think, one of the challenges too is even with that, diligent approach of testing baby, mom, and mom's milk, there's usually a little bit of a lag between getting all those tests back, sending them and getting them back. So, mom should definitely keep pumping, saving the breast milk. And then we hope that, we could clear mom and baby to go ahead and continue nursing. I share absolutely the same kind of anguish as you, Dr. Lawrence. But we're always, really just also similarly heartbroken when an infant gets CMV in the setting of SCID, because then we're really fighting an uphill battle.
Okay, great. Yeah, no, that gives me a lot more confidence in the reassurance of like, yeah, this is definitely one way or the other, talking with the mom about it. And then I guess just logisticals, a lot of times they like to know like timeframes. How long does it take to get like the flow cytometry back?
So if you're using a commercial lab, so like UVA's lab, it will be the same day. We do it in-house. If you're using a commercial lab, it's a 24-hour turnaround from the time the lab receives it. So let's just say you use Quest, for example. I'm not endorsing anyone, but let's just say you used Quest. You draw it in your office, the courier picks it up that afternoon. It goes to your local Quest, which ships it to the regional referral center. That's another day. And then another day after that. So we're probably talking about 3 days for you.
Okay. Yeah, I think that would be very doable for, like you guys were saying, like a really big risk. It's not like they have to wait weeks or anything for these tests to be done or to come back. All right. Well, thank you so much.
Thank you for the great questions. Really appreciate it.
All right, I guess we're all done here. I want you to know that in about 24 hours, if all IT issues are solved, this presentation will be on the site for you to view later. If you just have some questions later down the road, want to know if you remember everything correctly. And always you're free to email us to do patient case studies in the future. So if you guys are interested in that, please give us an email, okay? And have a wonderful day.
And we'll see you in 2 weeks. Dr. Lawrence will present yet again another wonderful talk on May 21st, same exact time. Thank you all so much for being here.